So today we're going to talk about continuous fetal monitoring. So first off, it's important to know why we do it and what outcomes it changes. So what has fetal monitoring or continuous fetal monitoring been shown to do? It's only been shown to increase the C-section rate. So does it decrease mortality or improve neonatal morbidity or mortality or maternal morbidity or mortality? That's right, it doesn't at all. And so the only thing it's been shown to do is it decreases neonatal seizure rate in the short term, but in the long term, there's no differences. So the only thing that it does, again, is it increases your C-section rate. So why do we do it? That's right, it's just because we've always done it, it's the standard of care. The alternative is to do intermittent fetal monitoring, which is cumbersome, and sometimes facilities and staff aren't equipped to do it. So we're kind of stuck with it. It's the world we live in. So unfortunately, whether you agree with it or not, you just have to learn the terms and be able to manage patients based off of it, because that's the standard of care that we live in, and that's the standard of care that we use to manage labor. So the next thing is, I know, and also they teach you the Dr. C. Bravado mnemonic. So you can use that if it's helpful. I don't really use it, but just use the same, always have a set just pattern that you go through so that you don't miss things. So the first thing on that Dr. C. Bravado was determine risk. So anytime you are interpreting a fetal heart trace, you should always be interpreting it in terms of the context of your patient. So in medicine, you always do this, whether it's labs or fetal heart trace, you take those data points and you take it in context of the patient that you're treating. So if you have a 25-year-old G2P1 with a prior normal delivery at term with a normal pregnancy versus a 35-year-old G1P0 who is late preterm with a history of IUGR, and you have the same fetal heart trace for both of those patients, well, you're going to interpret one of those a little bit differently. The patient with IUGR obviously is higher risk, and you're going to be more concerned about something like intermittent variables rather than intermittent variables in someone who's healthy with a normal pregnancy. So always remember that. Remember to determine your risk and interpret your fetal heart tones in context of the patient that you're taking care of. And so as you know, there are strict definitions with interpreting fetal heart tones. So the goal of this is for you to be able to interpret fetal heart tones and read any fetal heart trace by the end of this, and be able to communicate that with someone else who's not looking at the screen, so that they themselves can also picture that trace that you're looking at and visualize it in their head. So again, there are strict definitions. I want you to learn those definitions, and by the end of this, you should know what those terms mean. So when you use a term like reassuring or recurrent, you're using it properly and meaning exactly what the definition states that it means. So to start off, what is the first thing that we usually report on a fetal heart trace read when you're talking to someone? Correct, it's baseline rate. Baseline rate, okay? So what's a normal baseline rate? Yep, 110 to 160. Okay, and if it's less than 110, then what is it called? Correct, fetal bradycardia. And then if it's greater than 160, what is that called? Correct, fetal tachycardia. Okay, so the only one that we like is a normal rate, 110 to 160. Now, let's take a moment to look at the scale on our fetal heart trace. So if you look at the screen, you'll notice that there's an area that's highlighted blue. And so is this area the normal area? Nope, it's not the normal area. So it highlights 100 to 160. Some people don't notice that, so keep that in mind. So between 100 and 110, that's still fetal bradycardia. So just because you see that it's in the blue doesn't mean that it's normal. And that's just on our screen. So keep that in mind. So normal is between 110 and 160, not just the blue that's on our screen. The other thing that I want you to notice is the scale. So when you look at the scale, going across is time and going up are heartbeats. So on the time scale, how much is one big box? Yes, one big box is about 1 minute. And then 5 big boxes give you the dark black lines, which is 5 minutes. And then how much is one small box? This one small box is 10 seconds. And then one small box up is how many heartbeats? Yep, it's 10 beats for one box. And the reason why I bring this up is because sometimes you're looking for a 15 by 15, but it's easier to think in terms of boxes because what you're seeing is boxes on the screen. So if you're looking for 15 by 15, then how many boxes by how many boxes is that? Yep, it's a box and a half by a box and a half. So if you're looking for that 15 by 15 acceleration, you can tell yourself, all I need is a box and a half by a box and a half. And it's easy to just look up at the screen real quick and be able to determine that. Or if you need a 10 by 10, how many boxes is that? Yep, it's one small box by one small box, so 1 by 1. And so keep that in mind when you're looking at the scale. It'll help save you some time rather than having to pull up the screen or the paper and look real close at it. You'll be able to look at the screen a lot quicker. So this example that you see on the screen, you have to determine the baseline rate for this. And so baseline rate is rounded to the nearest 5. So you don't report a baseline rate of 112s, it's either 110s or 115s. And it's your call in terms of what you're calling the baseline rate. And it's important because if you call a baseline rate 110 and the heart rate goes up to 120, well, you might not meet the definition for acceleration. So your baseline rate kind of determines whether or not you have an acceleration or a deceleration. So whatever you call your baseline rate, just remember that so that you know your reference point for your accelerations and your decelerations. So in this example, what would the baseline rate for this patient be? Yep, you could say 130s or 135s. You could argue for either. And again, that's a judgment call. I think you could argue for either one, but just pick a baseline rate and stick with it. And another quick definition on the baseline rate is how is it determined? The baseline rate is determined by any 2-minute period that doesn't have to be continuous within a 10-minute window at which the fetal heart rate is at, which does not include any accels or decels. So, and that's part of the definition. It's kind of most people understand that and can just read that from the fetal heart trace. Okay, so we talked about baseline rate. And so what's the next thing that you usually report after baseline? Yep, variability. And there are 4 types of variability. What are those 4 types of variability? Yep, absent, minimal, moderate, and marked. What's the only type of variability that we like? Correct, moderate. So what is variability? They say they don't use this definition anymore. They used to say beat-to-beat variability, but I still think that's the best way to kind of explain it. It's the amplitude or variation in the heart rate from moment to moment on the heart strip that doesn't include any accelerations or decelerations. So you're just pretty much looking at the amplitude of the heart trace and how it changes from moment to moment, and it's defined by the amplitude. So if it's absent, what's the variation? 0. And so what does that mean? It doesn't necessarily mean a flat line like this, although this is absent variability, but if you can trace it with a pencil tip, and even if it's curving up and down like this, I can keep my pencil tip on it, that's still absent variability. The next one is minimal. And what amplitude range is that? Yep, 1 to 5. Okay. And then moderate, 6 to 25. And what's the amplitude for marked? Greater than 25. Okay. So again, we talked about scale, and we're talking about variability here. So in order to get moderate variability, how much of a box variation do you have to have? What does 6 correspond to? Just slightly over half a box. So you don't have to get much variation on your screen in order to get moderate variability. It's only half a box. So it ranges from half a box to 2.5 boxes. So remember that, because sometimes we see a fetal heart trace, a fetal heart tracing, and it looks like there's not much variability, but the definition of moderate variability is only a variation of 6 to 25 beats. So keep that in mind. So minimal variability can represent a couple of things, either things that are caused iatrogenically or something that the baby's doing. So what might cause minimal variability that the baby's doing? Yeah, the baby could be sleeping. So how do we test for responsiveness in the setting of minimal variability? Yeah, fetal scalp stim. And there are a couple ways to do that. What are those 2 ways to do scalp stimulation? Yep. There's a digital scalp stimulation during the vaginal exam, or there is vibroacoustic stimulation where you use a vibroacoustic device, put it on mom's pelvis just over baby's head, and vibrate the baby's head. Now what you're looking for in this setting is if you do the scalp stimulation and the baby has an acceleration or it becomes responsive and increases their variability. At that point, it's a positive fetal scalp stimulation or a reactive fetal scalp stimulation, which is a good sign. What are some iatrogenic things that we do that cause minimal variability? Yeah, if we give IV narcotics, morphine, Fetal, it can cause minimal variability. That effect isn't permanent, but just keep that in mind. Again, you're keeping the context of your patient in mind when you're interpreting these heart tones. So let's look at a few examples. This patient, what would you say the variability is? Yep, you could argue for both minimal or moderate variability. Again, moderate variability is just half a box of amplitude. So if you look at this heart tracing, there's at least some spots towards the last half of the fetal heart tracing where there's at least half a box of amplitude. But if you look at just the beginning, you're just looking at that first 2 to 3 minute window, it looks like there's minimal variability as the amplitude is not 0, but it's less than 6. It's less than half a box. So you can call this minimal variability, at least in the beginning. What about this next example? What is the variability on this fetal heart trace? Moderate variability, because the amplitude is somewhere between half a box to 2.5 boxes. And so that's moderate variability between 6 and 25. Again, that's the only type of variability that we like. So what is the variability on this next fetal heart tracing? It's marked variability. And marked variability is a variation in greater than 25 beats. Okay, so we talked about baseline rate, variability. What's next that we usually report? Accelerations. So what is the definition of an acceleration? Yep, most people know it as 15 by 15. So that's specifically for a certain gestational age though. If someone is greater than 32 weeks gestational age, then an acceleration is 15 by 15, which is how many boxes? A box and a half by a box and a half. Good. Now, if they were less than 32 weeks gestational age, What's the definition? 10 by 10, which is how many boxes by how many boxes? 1 by 1, okay? And so this is above your baseline rate. So accelerations are good things to have. And so, again, if you call your baseline rate 120s, your heart rate needs to go up to at least 135 in order for you to call it an acceleration. If you call it 125, it needs to go up to 140. So remember, what you call your baseline rate is important. It determines whether or not you have an acceleration or a deceleration. And so 15 by 15, box and a half for greater than 32 weeks gestation, and 10 by 10, which is 1 by 1 box for less than 32 weeks gestation, which isn't much. So remember that, because sometimes you'll look at a fetal heart trace and you'll forget that they're less than 32 weeks and you'll say, oh, there's no accelerations, but really there are, because it's only a box by a box. And so you just have to look a little closer and remember this definition. So this next heart trace is an example of acceleration. So are there accelerations here? So let's assume that this patient is greater than 32 weeks gestational age. There are accelerations. If you call your baseline rate 150s, there's at least 3 or 4 obvious accelerations in there that you can pick out just looking at it quickly. Now, again, it's 15 by 15 for greater than 32 weeks gestational age, which is a box and a half by a box and a half. And so when you're looking at the screen real quick, you can tell, okay, I definitely have a box and a half by a box and a half rise. And so eventually when you look at these heart tracings, you'll be able to just look at them on the screen, even though they're small, and be able to determine, okay, that's a heart tracing with moderate variability and positive accelerations. And so as long as you know these definitions and you constantly repeat them through your head as you're reading them when you're first starting out, that's how you'll remember them, and then it'll just become second nature to you, and you won't even have to really think about it. Also, the more that you teach these to the students or interns that you're working with, the more that it's going to be solidified in your own mind. Now, what about this patient? Let's say they're less than 32 weeks gestational age. Would you say there are any accelerations in here? Yeah, so like I mentioned before, it depends on what you call your baseline rate. Now, if you're calling your baseline rate 150s, there is a period spot in here where the heart rate goes up to 160 for at least 10 seconds, which meets the definition, because all you need is a box by a box, so 10 by 10. So we talked about the baseline rate, the variability, accelerations. What's the next thing that we report? Yep, decelerations. Now, there are 3 types of decelerations by definition. There are early decelerations, there are variable decelerations, and there are late decelerations. Okay, so what's the only type of deceleration that we're okay with? Correct, early decelerations are the only type of decelerations that we're okay with. So if you think about what causes them, you can more accurately troubleshoot through your conservative measures to target specifically what's causing the decelerations, and it'll make sense physiologically so that you'll be able to remember these interventions a little bit better. Early decelerations are caused by fetal head compression, okay? And most typically is between dilation between 4 and 7. And so it's just as the baby descends, the head gets compressed and you get early decelerations. Variable decelerations are caused by cord compression. Late decelerations are caused by what? Uteroplacental insufficiency. Okay? So those are your 3 different causes. Now, I will admit that you end up doing all the conservative measures anyways, typically in these settings, but some of them are more directed for a specific cause than others. So let's go through the definitions of each of them. So there's a set definition for each of them, which is important. So early decelerations, what they look like is they are decelerations that mirror your contractions. So in other words, the bottom of the deceleration matches up with the top of the contraction, and they start and end generally about the same time. But what's actually in the definition? Per the guidelines, there are 2 parts of the definition. The first part being that it's gradual. So what does gradual mean? It means the onset to the nadir is greater than or equal to 30 seconds, which is the definition of gradual. So it takes at least 30 seconds for it to kind of drop down to the trough. The second part of the definition is that the trough matches the peak. So that's the only part that's actually part of the definition, but they also say in general that the onset, the trough, and the recovery of the deceleration match up with the onset, the peak, and the end of the contraction. But the main part of the definition is that the trough matches the peak. Variable decelerations. So what do those look like? V for variable, so they look like V's. They're sharp and they're acute. And just like their name, they can happen at a variable time in relation to the contraction, either before, at the same time, or after the contraction. They're variable. So what is part of a variable deceleration's definition? Yep, a variable deceleration is defined as a 15 by 15 drop, which is the definition of abrupt or acute, steep, or non-gradual. So the way I remember this is 15 by 15 is the opposite of an acceleration. So box and a half by box and a half down. That's the only part that's part of the definition. So it's abrupt, which means it's 15 by 15. So if it doesn't meet that criteria, then it's not a variable. Late decelerations. So these are the ones that we worry about the most. So these are ones that look similar to earlies, but they occur generally after the contraction. So for late decelerations, what's part of the definition? The first part is that they're gradual. So again, we define gradual as the onset to the nadir of greater than or equal to 30 seconds. Okay? So it's gradual. And then the other part is, in general, the onset, trough, and recovery of the deceleration are after the onset, peak, and ending of the contraction. So it's in general. If you look back at the actual definitions, it doesn't say that it has to meet all three of those or even any of those. And so if it doesn't meet the definition for an early, you have to ask yourself whether it's a late. Now, you may find yourself in a situation where you talk to an attending and you interpret it based on everything I just told you here, and then based on what you say, maybe it's an early, but then you talk to the attending and they say it's a late, or you say it's a late based on what I've taught you and they say it's an early. It's not worth it to get into arguments with your attendings over definitions and whether or not something is an early or late. Just know your definitions and know what you've been taught that's in the guidelines, and I wouldn't get an argument with them because you can let them manage their patient how they want, but just as long as you know how to interpret it for your own reading. Because in the end, there is a high variation between, there's high inter and intra-observer variation in fetal heart trace interpretation, and it can be frustrating, especially as an intern, but don't let that get to you. Again, another thing you can do is, if you're not sure whether or not to call it an early or late, you can always describe it. You can say, well, there's a deceleration where it starts after the contraction, but it ends before the contraction ends. And you can let the attending interpret it however they want, but you're at least telling them exactly what you're seeing. Now, some of them may ask you to interpret it, and at that point, just make a decision. But sometimes it's better to err on the side of just being descriptive rather than giving your full interpretation of it. Okay, so there are two other types of decelerations that's not actually in the definition. So there are two other types of decelerations that I take into consideration too that you might hear about that aren't actually in the definition. So one of them is the term prolonged. So that term is used for both accelerations and decelerations. So what does prolonged mean? Yep, prolonged equals greater than 2 minutes. So if you have an acceleration or a deceleration that's greater than 2 minutes, then it's by definition prolonged. So the reason why I consider another type of deceleration, because if it's a prolonged early or late, you can't really say it's a prolonged early or late. It's just a prolonged decel because it's lasting probably beyond the contraction. The other one is a deep deceleration, which doesn't actually have a definition, but you'll hear people use the term, oh, those are deep decelerations. And in general, it seems to be used either when the rate is less than 90 to 100 or greater than a 40 drop from baseline. So there's not an exact definition, but if it's below 90 or 80, it's definitely deep. And so sometimes you'll hear people say, oh, we had a deep decel, or you can even have a deep prolonged decel. So you may hear those terms from time to time. So going back to our decelerations, what do you notice about the definition of early and late decelerations? Is there a time component requirement for early or late decelerations? No, there is no time component requirement. The only requirement is that it's gradual, so it takes about 30 seconds for it to drop to its low, and then a different definition in terms of the timing. So whether it drops 5 or 10 or 15, it doesn't matter. There is no minimum drop necessary for an early or a late deceleration. So if you call your baseline rate 130 and the heart rate drops down to 125, you might find yourself saying, oh, that's just a subtle, small drop. But a deceleration is a deceleration is a deceleration, or you might hear people say, a late is a late is a late. So it doesn't matter how far it drops. As long as it drops below your baseline, it's a deceleration if it meets just these two definitions. So you might also hear the term subtle late used sometimes, and that's also not a term. So again, like I said earlier, a late is a late is a late. It doesn't matter if it's subtle or if it's obvious. If it drops below your baseline and meets the criteria for it being gradual and the timing of it after the contraction, then it's a late. So even if it drops below just 5 below your baseline. So that's why it's important to know what you're calling your baseline so that you know whether or not you have a deceleration or an acceleration there. In this first example, what type of deceleration is here? Yeah, it's an early deceleration. And so is this deceleration dropping enough to meet the definition of an early? That's correct. It's dropping below the baseline period. There's no definition for how far it needs to drop. So it's gradual. It goes down to the trough in greater than 30 seconds, and the trough matches the peak of the contraction. So it meets the definition of an early. And what does this do to? Correct, fetal head compression, which is most commonly at a dilation of what? 4 to 7 centimeters. So if you see this, you might be expecting some change in your patient if they were were not 4 to 7 before. This next example, what type of deceleration is this? They're variable decelerations. And so variable decelerations typically are in what timing in relation to your contractions? Yeah, they are timed variably with your contractions. There is no specific timing. They are the opposite of accelerations, and they have to be abrupt, which is defined as what? 15 by 15, correct. Or how many boxes? By how many boxes? Yep, 1.5 by 1.5 boxes. And these are due to what? Fetal cord compression. Good. This next example has what type of deceleration? I would call these late decelerations. So these decelerations are only dropping down about 5. So they're barely dropping. So do they even meet the definition for a late deceleration? Yep, they still do because they're gradual. They take about 30 seconds or more to get down to the trough, and then their onset, trough, and recovery in general are after the onset, peak, and ending of the contraction. What are late decelerations due to? Late decelerations are due to uteroplacental insufficiency. And so these are the most concerning decels that typically people worry about. And these are the ones that you want to intervene for. This next one is an example of a prolonged acceleration. And where do you see the prolonged acceleration? Okay. And prolonged is defined as greater than how long? 2 minutes, correct. But it also has to be less than 10 minutes. If it's greater than 10 minutes, what is that called? A change in baseline. And this is an example. This next one is an example of a prolonged deceleration. Again, prolonged has a strict definition. It is something that is greater than how long? 2 minutes. So this is a deceleration that's greater than 2 minutes. And again, I told you this is kind of like the fourth type of deceleration, because if you can't really have a prolonged early or late or prolonged variable. It's kind of harder to define that. And then this one's an example of a deep deceleration. Again, is deep deceleration an official term? No, but we use it just in our OB vocabulary. So it's either a large drop from baseline, greater than 40, or a drop to less than 90. And so you can have deep decels that are prolonged, or a deep decel that's not prolonged. And so, again, it's hard to define whether or not it's a variable, late, early. It's deep. In general, we consider them to be worrisome. Okay, so we've gone through baseline rate, variability, accelerations, and decelerations, which is all the components of your fetal heart tracing interpretation. Now, there are a few other definitions that I want to go through before we move on. Okay, so one of those, like I mentioned earlier, is change in baseline, which is defined as a change that lasts longer than how long? Is greater than 10 minutes. Versus a prolonged accel or decel, which is greater than 2 minutes, but less than 10 minutes. The next thing is, you'll hear the term recurrent and intermittent. So what does recurrent mean? Recurrent means it occurs with greater than or equal to 50% of the contractions averaged over a 20-minute period. So if you have variable decelerations that occur with more than 50% of your contractions, say you have 6 contractions during that period and they occur with 3 of the contractions, well then those variables are recurrent by definition. So sometimes you'll hear people just throw around the term recurrent or intermittent, but they're throwing it around without actually knowing the definition. So the definition of recurrent, again, is it occurring with more than half of the contractions averaged over a 20-minute period. So what would intermittent be? Intermittent is less than 50% of the contractions averaged over 20 minutes. Okay, so if you have one variable in the span of 20 minutes when you had 8 contractions, well, it's just an intermittent variable. So why is this important? Because there's a different treatment for recurrent variables versus intermittent variables, and so it's important to use the term correctly. So again, you might hear the terms thrown around and used improperly, but remember what the exact definition is. Now you might run into a situation where you get 3 contractions in a row and you get 3 lates in a row. Now you wouldn't wait around for a whole 20 minutes to see whether or not it's truly recurrent or intermittent. You could be a little more descriptive and say, well, we've had 3 late decelerations with the last 3 contractions, or you can say they've been recurrent with the last 3 contractions. And again, you would intervene before you wait that full 20 minutes, even though the definition says it's average over 20 minutes. Just using common sense and just logic and managing the patient, you're going to try to step in sooner than later. Now, if you have a deceleration with a contraction, with every contraction over the last 10 minutes, well, you've already met the recurrent definition, because even if they don't have the deceleration with the next contractions over the 10 minutes, you've already had more than half of them have decelerations. The other 2 definitions are reassuring and non-reassuring. So reassuring is another term you might hear thrown around a little bit, especially with students and new interns. Reassuring is defined by 2 things: the presence of moderate variability or accelerations. Okay, so either thing is reassuring. So sometimes you might have a heart tone strip that has decelerations, but you'll say, but it's overall reassuring because there is moderate variability, or because there is accels, or because there is moderate variability and accelerations. So those 2 things make the fetal heart tracing reassuring. So what's non-reassuring is the absence of those 2 things. So we've talked about the fetal heart tracing definitions there. The next thing is the tachometer, or the contractions. So how are contractions typically reported by definition in the guidelines? Yeah, they're supposed to be reported as the number of contractions over 10 minutes averaged over 30 minutes. Okay. Here, just based on our culture, we typically don't do this. You might hear more often the contraction, there's a contraction every X number of minutes, okay? Which is how we often do it. So we might say there's contraction every 2 minutes, contraction every 3 minutes, but you could say there's about 3 contractions every 10 minutes, or 4 to 5 contractions every 10 minutes. Either is fine and acceptable. So if you have too many contractions, what is that called? Tachysystole, which is defined as greater than 5 contractions per 10 minutes. Again, averaged over 30 minutes. But again, typically, like for recurrent and intermittent decelerations, we don't wait the full 20 minutes. Again, we don't necessarily wait the full 30 minutes to determine whether or not something is tachysystole. You could say there's been 6 contractions in the last 10 minutes, which will make someone think that the fetal heart trace or the tachometer is showing tachysystole. So now you have everything you need in order to describe a fetal heart trace. And so, again, if I didn't mention this earlier, your goal when you're describing a fetal heart tracing to someone, especially when it's over the phone, or especially when someone doesn't have the fetal heart trace in front of them, which is often the case, you want to be able to describe it in such a way that that person that's listening to you can visualize and redraw that same tracing that you're drawing or that you're looking at. So your description should allow them to reproduce close to near verbatim what you're looking at on the monitor. So in other words, if you say, oh, we have a prolonged deep decel, and that's all you say, or you just say, oh, we have category 1 or we have category 2. You know, they could draw a category 1 or a category 2 strip, but how many different types of category 2 strips are out there? There's thousands, maybe millions, and it may not be the one that you're reproducing. So if you say there's a prolonged deep decel, well, prolonged, it could be anywhere from 2 to 10 minutes. So is it 2.5 minutes? Is it 8 minutes? Well, if you don't describe it exactly, then it's hard to say. If you say it's a deep decel, well, is it deep down to 100 or deep down to 60? Because I'm a little bit more worried if it's down to 60. So to be more descriptive, you can say we just had a prolonged deep decel down to the 60s for about 4 minutes, which is now recovered back to the baseline of 120s. Now, I could picture that in my head and redraw that probably exactly as you're seeing it, if that's how you described it to me. And then throw in there the other descriptors, that there's moderate variability, no accels, and then that decel that we described. And you can redraw that. Again, your goal as the person describing the fetal heart tracing is to be able to describe it in a way that your listener can reproduce it and redraw it in their mind or on paper exactly as you see it. So, taking all these things into consideration, they came up with guidelines for the category system. Okay, so there is 3 different types of categories. Okay. Again, in med school, you may have focused a lot on the categories because it was on your test, but obviously I haven't focused on it very much because it's more important in how you describe the fetal heart tracing and whether or not you know the definitions, more so than whether or not you know what category a fetal heart trace is. So when you're first starting out describing fetal heart tracings, don't just jump to the category. Because again, I said there's thousands of different category 1s, category 2s. And so with categories, we said there's 3 types of categories. 1, 2, and 3. Okay. So the thing about categories is we know one of them is good, we know one of them is bad, and the other one we have no idea about. So which one is the one that we like? Yeah, category 1 is the one that we like. Okay. Which one is the category that we know is definitely bad? Category 3. That's correct. And so there are strict definitions for category 1 and category 3. So you only have to know the definitions for those 2, and then everything else belongs in what category? Category 2. Okay. So let's start off with category 1. So think about everything good that you want in a fetal heart tracing. That's what category 1 is. So going through baseline rate, if it was good, what would you want? Yeah, baseline rate of 110 to 160, so a normal one. What type of variability would you want in a category 1 tracing? You want something good. Yeah, you want moderate variability. You want accels? Yep, accels are a good thing, but they don't have to be there. So plus or minus accels. And then if you were to have decels, which are the only type of decels you would be okay with? Early decels. So plus or minus early decels. That's the thing that people often forget, is that you can't have early decels, and also that you don't have to have accelerations. So all the good things are category 1. So very strict definition. Category 3, again, we said, is the one that's really bad. Also has a very strict definition. So I think of category 3 as being one of 2 types of fetal heart tracings. The first one is the most ominous one that most people remember, and that one is the sinusoidal one. Now this is very rare. I haven't seen it, but it's supposed to be representation of what condition in the fetus. Yep, fetal acidemia. And so it's about a frequency of, they say 3 to 5 in a minute, and that's supposedly what it looks like. Sometimes you might imagine that you see that on some heart tracings, but again, you take things in context of the patient that you're taking care of. So that's the first definition. The second definition that fits a category 3 is, so think about things that are bad. So what type of variability do you think would be really bad? Yeah, absent variability, which is what a sinusoidal is. So absent variability and one of two things. So what type of rate is bad? Bradycardia. So absent variability and bradycardia, or absent variability and recurrent variable or late D cells. Okay. Again, this is a very, very strict definition. And again, I harped on definitions and terminology and being exact with them. And this is where it comes into play, because this is absent variability and bradycardia, or absent variability and recurrent variable and late D cells. So they have to be occurring with more than 50% of your contractions and have absent variability. As you can see, this is a really strict definition. And I kind of bunched this into one, but I kind of think of all this as the same because it kind of forces you to remember that you have to have absent variability. Because sometimes you'll have some really ugly fetal heart tracings that are not category 3. So you could have minimal variability with a heart rate in the 60s, but that's still not category 3. Not by the definition that they set out. Now, would most people sit on a category 2 like that? Probably not. But this is what a category 3 is. It's only these two things. So it's a very strict definition. So if it doesn't meet category 1 and doesn't meet category 3, then what is it? It's category 2, which I call it the trash bin category. So again, we know 1 is good, we know 3 is bad, and then 2, we don't really have any great evidence for. So some people will subcategorize a bad category 2 versus an okay category 2. And when they say bad category 2, that means, you know, like the heart trace I just mentioned, where minimal variability with prolonged D cells down to the 70s or something like that, or something similar. So that's what they would consider a bad category 2. Again, it's still not a category 3, even though it looks awful on the screen. So this example shows some decelerations. And so are these decelerations recurrent or intermittent based on what you see? Yep, they're recurrent because they occur with more than half of the contractions, at least that are on the screen. I know it's averaged over a 20-minute period and we only have about 10 to 12 minutes on the screen, but at least on what you see, they're recurrent. Or another way that you can describe them is that there have been X number of decelerations with the last X contractions. What about this fetal heart tracing? There are decelerations present. Are they recurrent or intermittent? They're intermittent. And why do you call them intermittent? Yep, by definition, intermittent occurs with less than half the contractions, at least based on what you can see on this 10 to 12 minute strip. These decelerations are occurring with less than half of the contractions. This fetal heart tracing, would you describe it as overall reassuring? Yes, so why would you describe it as overall reassuring? What things are there that make it reassuring? Yep, moderate variability is one aspect of a reassuring fetal heart trace, and positive accelerations is another aspect of a reassuring fetal heart trace. So in this example, I want you to read the contractions. So how would you describe the contraction pattern on the tachometer in this fetal heart trace? You could describe it as contractions once every 2 minutes, or 5 contractions in the last 10 minutes. Again, you don't have a 30-minute window to average it over, but you're describing it well enough that someone can visualize what you're describing. In this example, how many contractions is the patient having within 6 minutes or within a 10-minute window? Yep, 6 contractions, which by definition make this tachysystole. In this example, though, are the heart tones reassuring or non-reassuring? They're reassuring, so you don't necessarily have to do any intervention to address this if the patient's not on augmentation or not on Pitocin. Now in this example, there's tachysystole, but the fetal heart tones are non-reassuring. So what would you do in this situation? Either stop the Pitocin, decrease the Pitocin, or initiate your conservative treatments before going in even any further. So we've gone through how to read a fetal heart trace, some definitions, how to categorize your fetal heart tracing, and then how to read the tachometer, and how to read your contraction pattern. Now, when you get decelerations that you don't like variables or lates, or variability that you don't like, or a category that you don't like, 2 or 3, we start to initiate certain interventions. And so, what are those interventions? We call them conservative treatments, but what are they? So there's 4 things, 3 main ones and 1 depending on your patient. So the first one is repositioning. So with these treatments, I want you to think about how they work, and then what's causing your decelerations, and how they might be addressing the cause of your deceleration. So the first one being repositioning, what's happening in that case? Yes, often the nurse does this on her own, where they'll move the patient to the left or the right, and what it does is, if they're compressing the IVC, it might push the baby off the IVC and give better blood flow, or if the patient is, or the baby is compressing the cord, as they move the patient, the baby might be coming off the cord to help solve this problem. So repositioning is one of them. What's another conservative treatment that often is initiated by the nurses before we even go in the room? Yep, IV fluids. So how do IV fluids work? Yeah, if the mom's hypovolemic or dehydrated, doesn't have enough volume in the vascular space, by giving IV fluids, you're theoretically expanding that, and it may be helping to uncompress the cord, or just getting more oxygen and volume delivery to the baby. Maybe if there's some placental insufficiency, you're just trying to deliver more volume to the fetus. What's the third conservative treatment? Oxygen. So you're giving mom more oxygen, which puts more oxygen in her blood, which delivers more oxygen to the baby. So maybe if you have some placental insufficiency, you're getting more oxygen delivery there. That might help baby. And so think about how these treatments are working, what your main problem is, and that might help you decide on what treatments to initiate first. Now, to be honest, we do all of these things at once, but there's some situations like, say the mom saw some blood, got dizzy, passed out. Well, what's the first thing that you want to do, probably, out of all these? Maybe the IV fluids, but definitely want to put oxygen on her, because if she's passed out, she's not breathing as much, and she's not getting as much oxygen. Baby's probably not getting as much oxygen, and it wouldn't be surprising if the baby has a decel shortly after that. And so, or a mom has a seizure. Anyone that typically comes in with a seizure, what are you going to do? You're going to turn them on the side and put oxygen on them. So it's no different with a pregnant mom. And so you're going to, in reality, you're going to do all 3 things. But, if you think through the causes and think through what's going on with the patient physiologically, it may help you to make decisions quicker or easier and prioritize them a little better. Now, I said there was a 4th thing depending on the patient you had. So what's the other thing that we can do which is more of a thing that we're stopping. So we're gonna either decrease or stop. So if they're on Pitocin, just turn it off, or you can decrease it if you want, depending on how bad the heart tones are. Now, I wouldn't say there's a right or wrong answer, but if you have a prolonged deep decel into like the 50s, you're probably gonna just turn off the Pitocin right away. So sometimes we forget that when we go into the room. And just per our protocol here on our OB floor, without an attending's approval, if you stop the Pitocin for longer than how long do you have to restart it at the very beginning? Yeah, if you stop the Pitocin for more than 30 minutes, you have to restart it again from scratch. And so that's just our hospital protocol. And if you have attending approval, you can restart it a little bit higher. Now again, these are conservative treatments that are typically done by the nurses right away when we have non-reassuring fetal heart tones. So category 2 or category 3 fetal heart tracings. So, but you as the physician who is taking care of the patient, anytime you have changes in your fetal heart tones that you need to address, when you go in to the room to see the patient, what's the first thing you need to do? Nope, not oxygen, not IV fluids, not repositioning. You check the patient. So the first thing you always do is you check the patient. You check the patient, you check the patient, you check the patient. I can't emphasize that enough. It seems really simple, but it takes at least a couple months to finally hammer it home in your mind to remember to do that. So what happens if you just check the patient 5 minutes ago, you go out of the room and then there's a couple of deep variable decels, and you go back to the room. So you just checked the patient 5 minutes ago, what should you do? Correct, check the patient. So again, the first thing you do is you check the patient, you check the patient, check the patient. Because the last thing you want to do is you call the laborist because you have a big decel and you're freaked out. You call, we've just had a big decel down to the 90s for about a minute, and while you're panicking and trying to get things together in your mind, Dr. Brantley stops and pauses and asks you, what's the patient's check? And then you have this sinking feeling in your heart and you're like, oh shoot, I didn't check the patient. And you tell her, sorry, I'm going to have to check the patient, I'll call you back. Only to find that the patient now is completely dilated and ready to deliver a baby. So often, the baby is trying to communicate with you that there are things changing in its environment. And so often a big decel might be an indication that the mom's just dilated really quickly from a 6 to complete. So always check the patient, check the patient, check the patient, even if you just did it 1 minute ago. Because who's to say that all moms dilate gradually over the span of 4 hours rather than at a single point, and you don't see that just because you're only checking them every 1 to 2 hours. So always remember that. The next two things that we're going to talk about are two of the interventions that we do in terms of procedures on the OB floor, and there's specific indications for both of them. So the first one is an FSE, or sometimes you'll hear some physicians call it a DFM, which is a direct fetal monitor. So don't be thrown off by that term. So there's only a couple of reasons to put in an FSE, at least in my opinion. One of those reasons is not because the nurse can't find the baby on the monitor. So if that's the reason, then they should have failed after trying multiple times, also another nurse failing. So if you truly can't find the fetal heart tones or can't trace it, then you can put an FSE on. But Not if the nurse just calls you and is like, I can't keep this baby on. Can we just get a FSE on? Especially if you get the feeling that they haven't been trying for all that long, and if you walk in the room and you put the monitor down and the baby pops up right away. And it's not a reason to put it if they're just having to do a lot of work keeping the baby on. If they can find the baby, it's fine, because it's a procedure and there's risk with doing that as well. It's not a benign, no procedure is benign. So the other reason is, in my opinion, is if you've had really bad fetal heart tones. So you go in the room, you've had a prolonged deep decel down to the 60s for about 3 minutes. You probably want to throw an FSE on there, because you want to know that you're tracing the baby and actually getting the baby's heart rate, especially because you're going to be moving the mom a lot, maybe back to the OR, and you want to know exactly what your fetal heart tones are. And so in that situation with bad fetal heart tones, typically prolonged, deep, or recurrent. So those are reasons to put an FSE or a DFM on. And we're not going to talk about how to do it, but those are the indications. The other procedure that we do is called an IUPC. And in my opinion, there are only 3 reasons to put an IUPC in. So there is a therapeutic reason, there is a diagnostic reason, and there is a monitoring reason as well. So what is one of those reasons? If the therapeutic reason is to give an amnio infusion. So in order to put an IUPC in, what does the patient's membrane status have to be? Yep, it has to be ruptured. You could theoretically stick an IUPC in between the membranes of someone who's not ruptured, but they need to be ruptured in order for it to be effective. And so in order to administer an amnio infusion, you need an IUPC in. And there's only one indication for an amnio infusion: recurrent variables. So again, think about what the cause is, think about what you're doing physiologically, and how it works. So variables are caused by what? Fetal cord compression, especially maybe after you've broken their water. So an amnio infusion puts fluid back into the uterus, and so how might that be working? Yeah, so the amnio infusion increases the fluid in the uterus, which might push baby off of the cord and give the cord more room to expand and decrease cord compression. Again, it's for recurrent variables, not intermittent variables. It's also not for meconium. It's also not for recurrent lates, although you'll see some attendings do it for recurrent lates, and you'll also see some attendings do it for thick meconium. But it's not indicated or proven to be of any benefit for that. It has been shown to be a benefit for recurrent variables, which is due to cord compression. And if you think about what's causing it, how it works, it makes sense, which most things should in medicine when you're doing things. What's the next indication for an IUPC? To diagnose low MVUs. So if you want to check MVUs in the setting of no cervical change or slow cervical change. So if your patient is changing every hour, dilating a centimeter every hour, and you can't get the contractions on the monitor, does it matter? No, it doesn't matter. Are they adequate based on their contractions? Well, you don't know what their MVUs are, but it doesn't matter. They're adequate by definition because their cervix is changing. So if their cervix is changing, you don't really care where their contractions are, and so they're adequate by definition. The tachometer on the outside, does it tell you how strong the contractions are? Nope, they just tell you when the contractions occur. The IUPC tells you how strong they are, so that's why you can calculate your MVUs. How are your MVUs calculated? Yep, it's the height of your contractions added up over a period of how long? 10 minutes. And you want your MVUs to be greater than or equal to what in order for them to be considered adequate? 200 MVUs is the cutoff for adequacy. So what is the third reason to put in an IUPC? So is a poor toco tracing enough of a reason to put in a IUPC? Nope, not in my opinion. You have to have a poor toco tracing and D cells. So why is this? Let me illustrate an example to you. So if you had D cells that look like this, okay, what are these D cells if you don't have a toco tracing? So by definition, they're gradual and occur over greater than 30 seconds, assuming this is 30 seconds on this pseudo time scale. They're not abrupt, they don't look like variables. So they could be earlies or lates, right? Because earlies and lates, they look the same. The only difference is their timing. So if you have a poor toco tracing and D cells like this, well, they could either be earlies or lates. Well, that's a significant difference whether they're earlies or lates. And so this would be a reason to put an IUPC in. Because if you put an IUPC in and it comes out looking like this, are you as concerned? Correct, you're not. What type of D cells are these? They look like early D cells by definition. Now if you put your IUPC in and you see that your contraction pattern looks like this in conjunction with your D cells, well then what are those D cells? Yeah, they're late D cells and you're more concerned. So that's the third indication for an IUPC. So there's only 3 reasons, in my opinion, to put in an IUPC. That's an amniofusion, a therapeutic reason. For recurrent variables, it's for arrested or protracted labor. If you're trying to determine whether or not the mom is adequate or the uterus is adequate, and you want to calculate MVUs. Again, if you're having cervical change, the mom is by definition adequate, and you don't care what your MVUs are. Your goal MVUs are greater than 200. And then the third reason is if you have D cells in the setting of a poor toco tracing, you need to characterize whether they're earlies or lates. Let's look at a few examples. In this first example, you can see can't really trace the baby at all. There's contractions. I don't even have enough fetal heart tracing to determine whether or not it's really reassuring even in between. And sometimes you'll look at a fetal heart trace and things will pop off, and typically heart traces don't drop 90 degrees. And so if you see something that's low that you think may not be the baby's, what's something that you can have put on the patient or have the nurse do? Correct, you put on the pulse oximeter to get mom's pulse, because that could be mom's pulse. So it's always important when you have these cells to put on mom's pulse oximeter to get her heart rate on the monitor as well and compare. Because sometimes the CEFM picks up mom's heart rate instead of the baby. And so usually you won't see an abrupt 90-degree drop in your heart rate on the baby. It'll be more gradual than that. So if it's 90 degrees, it's more likely dropping down to mom. But on this example, you don't even have enough to really say that baby's heart tones are reassuring. So this might be an example to put in an FSE, or a time when you would want to, if you indeed cannot get the baby on the monitor. So in this fetal heart tracing, there are decelerations. Can you characterize the decelerations or describe them for me? Yeah, these are what look like variable D cells. Are abrupt, at least 15 by 15 or a box and a half by a box and a half. And they are also, are they recurrent or intermittent? Recurrent. So, and these D cells are being caused most likely by what? The cord compression. And so what is a treatment for recurrent variables? An amnioinfusion, which you need what device for? An IUPC. So this would be a time when you can put an IUPC in for an amnioinfusion for the indication of recurrent variables. Now, is it indicated to do an amnioinfusion for a thick meconium or recurrent lates? No. Okay. For this example of fetal heart tracing, what category would you describe this as? Yep, it's category 1, which, just to review, has what baseline? If 110 to 160. What type of variability does a category 1 have? Moderate variability. Do accelerations need to be present for category 1? Nope, they don't have to be, but if they are, that's fine. And then what type of decelerations can you have in a category 1? Can you have any? You can have early decelerations, and those are the only type of decelerations that you can have. So this one obviously is a category 1, and the more that you go through the definitions and kind of repeat to yourself each time, as you're reading through these, you want to say, okay, this is a normal baseline between 110 to 160, and then this is moderate variability because it's 6 to 25 variation, or half a box to 2.5 boxes. There's accelerations because there's box and a half by box and a half above the baseline, and then there's no decelerations present, which make this a category 1. And so eventually you'll be able to just look at the screen and say, okay, that's a category 1, or look at a screen and be like, okay, that's not a category 1, and you look at it closer. But you only get there by continually repeating these things to yourself or teaching others as well. So this next example is what category? Yep, it's category 2. You could have arrived there by knowing that it's category 2, or just knowing that it's not category 1 and not category 3, and by default it's category 2, which is a trash bin diagnosis. So what makes this a category 2? This next fetal heart tracing is what category? Yep, it's category 3, which is a very hard category to meet, and there are strict definitions for it. And so category 3 is one of two things, as I mentioned before. It's either sinusoidal or absent variability plus either bradycardia or recurrent variables or late decels. So very strict definition. This we know is bad. This is an example of a shoulder, which sometimes you'll get into some debates or a little bit of confusion in terms of dips in the fetal heart tracing coming off of an acceleration shoulder, or a rise in the heart rate coming off of a deceleration. And to be honest, I don't know the right answer to this, and I don't think there is a right answer, or at least not in the guidelines, in terms of whether or not a short decel after the shoulder of an acceleration is really a variable or a late. Some people will say they don't count as deceleration, some people will say they do. And so I would take it in context of your overall fetal heart tracing. If it's overall reassuring, you got moderate variability and accelerations in a mom who's been otherwise healthy, it's probably not a big deal. But if you had a mom that's had recurrent intermittence, or you've had a run of lates throughout the labor process, then it's probably a little bit more concerning. But again, you're taking it in the context of the overall picture of the fetal heart tracing and the other aspects of it, rather than just that isolated decel coming off of a shoulder. Again, just to review and hit on some of the high points. So again, fetal monitoring has been shown only to increase your C-section rate, but it's the world that we live in, and it's the standard of care that we have. So it's important to know definitions, how to describe them, and also how to interpret them and how to address them and treat them. It's also important to know how to describe fetal heart tracings to your listeners, and you want to give them an exact definition and err on the side of being more descriptive rather than going to categories, because your goal as the person describing the fetal heart tracing is to be able to describe it in a way that your listener can reproduce the exact image in their mind of what you're seeing. And again, we went through how to read a fetal heart tracing, starting at the baseline rate, variability, accelerations, decels, other definitions that we have, and then how to read the tachometer. And again, it's taken in context of your patient that you're taking care of. And then we also learned how to categorize them with category 1 and 3 being very strict in definition, 1 being good, 3 being bad, 2 being your trash bin. How to treat those based on our conservative treatments, and also whether or not to use procedural interventions with FSEs or IUPCs. And then whenever you have a concern or a change in the clinical status in your fetal heart tones or your patient, the first thing that you always go do when you enter the room is you check the patient, check the patient, check the patient. Another thing is a late is always a late is a late, no matter how subtle it is. So as long as you repeat to yourself these definitions as you're going through them, especially when you're starting off, every fetal heart tracing that you read, go through these definitions in your mind until you have them down, and teach them to others until you have them down. Only then will you get real comfortable with reading fetal heart tones. It's probably the most important thing to learn your first month as you're going through OB.